Welcome everybody to this month's Teach Educational Rounds. Here with us today we have Dr. Laurie Zawertailo and Dr. Peter Selby, who will be presenting on Quitting Vaping, a Cessation Guidance Resource. So let's get started with our land acknowledgement. KMH is situated on lands that have been occupied by First Nations for millennia. Land rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of KMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty No. 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. KMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So I'll now strongly encourage everyone in the chat to let us know which traditional territory you're joining us from today. If you're unsure, you can visit the website there, so www.whos.land. I can put that in the chat in a moment. And you're also welcome to let us know one thing that you're doing to learn or improve your commitment to reconciliation. So I'll give everyone a few moments to do that in the chat. And I will share the link in case you need that. Welcome, Sarah. Thank you for sharing. We'll give everyone else a moment to share. Welcome, Luda from Six Nations of the Grand River. Welcome, everyone. Wonderful. We'll give everyone a couple more seconds and then we'll keep going. Wonderful. So feel free to keep sharing in the chat. I will just keep going on with some housekeeping items. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you registered for the webinar and completed the pre-learning assessment. As well, please make sure you signed into the webinar using your full first name and last name so we can track your participation. And lastly, make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of tomorrow. And along with that, we will be sharing the presentation slides and the recording as well. So here's a little bit more information on our first presenter today, Dr. Laurie Zawertailo. Laurie obtained her PhD in pharmacology at U of T in 2002. She did her postdoctoral fellowship in tobacco use in special populations at KMH and has been a scientist at KMH since 2005. Dr. Zawertailo's research interests are in the areas of behavioral and neurobiological aspects of tobacco dependence and treatment, especially in individuals with comorbid depression and alcohol use disorders, subpopulations who have an especially high prevalence of tobacco dependence and tobacco-related morbidity and mortality. Dr. Zawertailo utilizes a variety of techniques to approach this research question, including neuroimaging, behavioral and cognitive tasks such as cue-induced craving, genetics, randomized clinical trials, and large population-based approaches to smoking cessation with over 80 publications in this area of research. Her goal is to understand the neurobiological and behavioral processes involved in nicotine use and addiction, including e-cigarettes, in order to optimize treatment outcomes. She is the co-principal investigator of the STOP program, a province-wide cessation program that has provided treatment to over 250,000 Ontario smokers. So welcome, Laurie. And here are just her disclosures. Next up, we have Dr. Peter Selby, who is a senior medical consultant and a clinician scientist at KMH. He is the interim vice chair of research, DipABAM professor, and director of addictions and mental health division for the Department of Family and Community Medicine at U of T, and a full professor in the departments of psychiatry in the Della Lana School of Public Health, and a clinician scientist in the Department of Family and Community Medicine. His research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. He also uses technology to combine clinical medicine and public health methods to scale up and test health interventions. His cohort of more than 300,000 treated smokers in Ontario is an example of this work. So welcome, Peter. And here are his disclosures. Please note that the content of Teach educational rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So with that, please feel free to use the chat feature throughout the webinar to post any comments or any questions or answer any prompts from the presenters. To do this, you can click on the speech bubble icon in the control panel at the bottom, and please ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. And you're also welcome to use the reaction feature if you would like to send a smiley face or a thumbs up. That is always welcome. So with that, I will leave it to our presenters to take it away. Thank you, everyone, and enjoy the webinar.
Great. Thank you very much, Natalie. Welcome, everyone. Thank you for spending your lunchtime with us. So today we're going to talk about what we've been working on for the past several months, trying to develop a guidance document for practitioners on vaping cessation. And so the learning objectives for today are to describe the methodology that we use to create this resource, to investigate the recommendations that comprise this cessation guidance resource, and then to discuss how these recommendations can be applied to your practice. So we came up with a few kind of clinical dilemmas that some of you may or may not be able to relate to. Dilemma number one, a 17-year-old vaping a pod-based device like a Juul. He's a never smoker, he's unable to quit on his own, and he wants NRT. And so the questions are, should I give NRT, and if so, what dose? A second possible scenario, a 46-year-old dual user of both cigarettes and e-cigarettes. And they want to know, they're asking you, which should I quit first and how? How do I go about doing this? A third scenario, a 35-year-old pregnant woman, 30 weeks pregnant, is vaping one pod of 6% nicotine, but is finding she needs more to stay out of having symptoms of withdrawal. And then again, a 25-year-old postpartum woman, 12 weeks since giving birth, and she's feeling like she's at risk of relapsing to vaping, even though she quit during her pregnancy. So we know that, e-cigarette usage is increasing year over year in Canada, and that the CTAD survey has shown that Canadians 15 years and older, that over 16% as of 2019 have tried an e-cigarette. So these are quite common, at least for experimentation. And furthermore, over 5% have used them in the past 30 days. And this has increased year over year since 2013. Again, most people who in Canada who use an e-cigarette use an e-cigarette that contains nicotine, and so they're at risk of developing symptoms of dependence or addiction. So you know, it was important to us and to the Ministry of Health to start develop a guidance for clinicians on helping people quit vaping, because we've heard from you that this has become an issue. People are coming to you, your patients are coming to you asking for this help. So the aim, or the primary objective, was to develop a guidance for healthcare providers to support their clients who want to quit vaping. And we wanted to develop a resource that could be used for both adults and for youth, ages 15 to 24. And because you know, nicotine is such an addictive substance, we specifically wanted to develop a guidance for people who use e-cigarettes containing nicotine only. And we weren't going to get into the weeds about vaping cannabis or anything like that. So this is vaping nicotine. So last summer, we, in collaboration with OTRU, did a systematic literature review, a scoping review of everything that is out there regarding vaping cessation. We've drafted a manuscript. It's currently under review at the Canadian Medical Association Journal, so hopefully we'll get some positive reviews and that'll be published soon. And then the next step after this literature review was to convene a Delphi panel. It's kind of a modified Delphi panel of both experts around the world, and we also had a peer panel, so people with lived experience that we wanted their input as well. Then in January and February, we drafted the guidance based on the feedback from the panel, and we're now doing knowledge translation, evaluation, and we have a finalized resource, I believe, finally. So the aim of the initial literature review was to summarize what's currently out there, the current recommendations for cessation interventions for people who use e-cigarettes or who are dual users, using both electronic e-cigarettes and tobacco cigarettes. So we searched all of the relevant databases and also gray literature, so documents from government agencies and other reputable organizations. There were 12 papers included in the final review. And almost all of these papers were youth-focused. An asterisk there were actually no randomized controlled trials and no papers on interventions for dual users. So these are real gaps in the evidence base and the current literature, and things that kind of limited some of our guidance and advice. So our main findings of this literature review were that behavioral counseling mostly via web-based resources and technological aids may be effective in helping people, especially youth, reduce or stop vaping. It's important to use a validated tool to assess the severity of vaping dependence, and vaping cessation aids like a quit plan, etc., may be effective tools to help your clients. Again, some evidence, mostly anecdotal or case reports, that medication can also be used in combination with behavioral therapy. But again, no actual trials have been done in that. So there is, as I said, a real lack of evidence in support of effective vaping cessation or dual use cessation interventions. More research is needed, obviously. And as I said, this manuscript is pending publication. So then, you know, in the absence of any real evidence, you have to turn to the experts, you know, the people that have a lot of experience, either with treating smokers or vapors or dual users, and asking them what their advice would be. And so, you know, we use this modified Delphi panel where, you know, we defined initial research questions, we selected a panel, we designed the survey, and then we did several rounds of this survey, and we came up with consensus on some of the summary statements and the guidance that we developed. And we defined consensus as having 80% agreement amongst the panel members. So we had kind of two panels. We had our expert panel made up of 24 experts from around the world, and our peer panel where we had 4 people with lived experience, 2 youth and 2 adults. So as I said, 24 people in the expert panel, 10 were local, and 6 were from other parts of Canada, and 8 were outside of Canada, UK, US, Australia, New Zealand, I believe. And then our peer panel comprised of 2 youth and 2 adults. So after going through all the rounds and getting consensus and we developed this guidance resource. We tested the guidance resource amongst some healthcare professionals and the peer panel, and we incorporated their feedback from this usability testing, and then we finalized the resource. So I think Peter's going to walk us through the resource.
Yeah, thank you very much, Laurie. And Madeline, I hope the sound is not cutting out. Just let us know if it is. Yeah, just let me know, okay? All right, so moving right on. Let's see. Okay, so what we're going to do is looking at the guidance resource overview. Pretty much as we went through it, we decided that we needed to tackle some major issues. So that the guidance is divided into obviously severity and dependence. What are some of the general approaches that we can take? What are the treatment approaches? Really addressing the issue of dual use. Should we use medications, and if so, how and what? What behavioral therapy strategies are there? What about harm reduction and relapse prevention? So how we've created the resources, we've come up with recommendations. And again, if any of you work in guidelines, this would be really expert recommendations. These are not with good randomized controlled trials, but the recommendations the expert gave are highlighted in purple. But there was lots of discussion and said, we need to think about these special considerations when you're making a recommendation. How does this apply to a different kind of population or person or situation? Those are highlighted in orange. And then what additional supports are required, which are highlighted in yellow. So there's a color coding, purple, orange, yellow. And again, we used a little bit of icons to suggest, who is an adult, youth, and obviously we wanted to make sure we spoke around pregnant, breastfeeding, or chest feeding individuals, and then people with mental illness or substance use issues for specific consideration. Again, I can tell you that this was a really quick, we had a very short timeline. It had to be done by end of fiscal year. We had roughly about 3 months to get it done, or less, if you actually look at the time. Anyway, then again, this is a general guidance. And again, it's not been adapted or co-created with specific vulnerable populations or so again, I think if you're going to work with people who've been made vulnerable or do not fit sort of, the general population rubric, you must take some time with them to see how this resource or guidance works and not be dogmatic about what we're doing. So it's really important to understand people's social cultural diversity, and regardless of it, use a trauma-informed and person-centered approach with creating a treatment plan for people who want to quit vaping. Sometimes people say you should just continue vaping, but there are people there who don't want to be addicted. Even though it may be less harmful than smoking, they just don't want to be vaping. So we do need to pay attention to that and not force them to continue. Sorry about that. So if you take a look at all the again, we had to rely heavily on smoking cessation guidance because that's the longest, and the most studied tobacco product. And we said basically, given how common it is, it makes sense to ask everybody if they vape. And if they've formally smoked and are advised to quit vaping, we should monitor them to relapse going back to cigarettes. So yes, you don't want to be addicted to vaping, or you don't want to be using a vape device, but when you quit it, you go back to cigarette smoking. That's really not a good thing. If you are exploring people's vaping behaviors, then the assessment should have questions on dual use of what else they're using, what other tobacco products, especially cigarettes. What is their physical and mental health issues going on, their social and environmental factors. So for example, somebody else vaping, vaping use policies at home. We have seen a lot of people continue to vape because it doesn't have the same kind of stigma or the same kind of restrictions in their minds as smoking. You'll see vaping happening, while indoors now and continuously. So they don't necessarily use discrete episodes; they're just constantly grazing through the day. There are some standardized tools to assess vaping dependence to inform treatment plans and to facilitate discussions with clients. So it's not a bad way to look at the various dimensions of vaping behavior, so that can guide you as well and them as to how dependent they are. And of course, there was no recommendation of which of them should be used to assessing vaping dependence. You can use one that best suits the needs of your client and your situation. So for example, for the adults, there's the EFTND, and that's kind of a modification of the Fagerstrom test when cigarette dependence or nicotine dependence, whichever way you want to call it, something called the EDS and the PSECDI. And then for youth, there's the hooked on nicotine checklist, which has been used for tobacco as well, and then the EDS. And you can see the EDS can be used for both. So those are some of the things to think about. You can basically think about which one you want to do. There is no consensus amongst the experts on the use of language around nicotine use disorder and nicotine dependence. This went out for much, and none of us could agree whether this qualifies as nicotine use disorder or nicotine dependence when referring to people who vape and want to quit. And so really there is no, and that basically points that we need a lot of work to be done to get rid of that. Okay. Moving to the next slide. So that's the severity dependent. Of course, we want to make sure we pay attention to people with mental illness or substance use disorders. We, again, like with smoking, we need to assess how severe and where they are in their journey of their substance use disorder and mental illness. Definitely consider the impact of nicotine use, subsequent nicotine withdrawal, and the effects of smoking cessation medications on current medications or other substances being used. So for example, somebody is vaping, they can be vaping quite heavily, even though the legal limit is 20 milligrams. We are seeing people or reports of people getting up to the 50 milligram, and they're using 1 to 2 pods a day. And so they're feeling really dependent, and suddenly precipitating withdrawal in them is not a good idea. So be mindful, because you may cause nicotine withdrawal, which is associated with anxiety, irritability, restlessness, etc. We also want to make sure that we take a sex and gender plus approach to ensure clients' needs are met, given the different levels of nicotine use that can be achieved through vaping, the motivations for use, and the reasons for quitting. Some of them may be for concentration, others may be for weight control or body image or things like that. So it's really important to understand the person's personal experience of vaping. Now, again, if there are adults, youth, people who are pregnant, breastfeeding, or chest feeding, and people with mental illness or substance use issues who quit smoking and have continued to vape, they should be advised to quit vaping. Now, how long they've been vaping for, we could not necessarily come up with a date, like, oh, it's been 3 months or 6 months, but in general, roughly, if it's stable and they're finding it that they're getting hard to come off vaping, they should be advised to quit it. But especially those who vape but have never smoked should be advised to quit smoking. And this is more important in our minds than anything else, is that we really need to get people who've never been smokers to quit vaping as soon as possible, so they don't end up developing a nicotine dependence. Because although nicotine itself is a lot less harmful than a cigarette, nicotine itself has some health effects that may not be good in the long term. So clearly, if they don't need to be on it, you really don't want people to be doing it. There's no agreement on the recommended general approach for the treatment who are both smoking and vaping and are seeking help to quit. So so whether they should quit both simultaneously, quit smoking before quitting vaping, or quitting vaping before smoking, could not reach a consensus about that. And so where we suggested is that, given the lack of evidence, given the lack of consensus, a healthcare provider, what are you supposed to do? Is take a person-centered approach and ask, how do you want to quit? They quit altogether, one at a time, which one first, and they can make an informed decision about which one is available. And really, this is where you can say the evidence is not one way or the other. You decide what's going to work for you, and we'll support you in that attempt. Again, people generally should be made to understand that if both products are harmful, smoking is likely associated with greater exposure of harmful chemicals. So that idea that a lot of people are feeling that they're equivalent should be educated that no, from a harm reduction perspective, you're getting a lot less exposure when you vape than compared to when you smoke to a lot of chemicals. But also explain that there are potential health risks with long-term e-cigarette use, and some of them are unknown. And so, but overall, just common sense will tell us it's unlikely to be worse than what people get from smoking cigarettes. The only issue is one is known and the other isn't. When you're trying to develop a person-centered treatment plan, also consider people's sexual orientation and role that discrimination, stigma, and trauma play in nicotine use. There is a huge uptake on how nicotine is used by different people and how they've gotten addicted. So making sure that when you're helping people come off, that you're really understanding where they're coming from and take a trauma-informed approach into your intervention. One of the things is when somebody quits vaping, consider that there's no compensatory increase in other substances, especially if they have other substance use disorders. And then they aren't compensating by taking on more harmful substances in terms of the route of administration, like quitting vaping, but now starts vaping THC oil, or starts smoking cannabis or drinking more alcohol, or getting worse in that way. So keeping in mind that that's an important thing to do. All right. Now, again, the duration of treatment, we try to figure this out. How long should duration be? And we went, again, with what tobacco treatment and some of the evidence suggests, that minimum of 8 weeks is required for people to sort of get that, but 12 weeks, 8 to 12 weeks, somewhere there, because we do know that there's associations, at least with cigarette smoking cessation studies. If people are able to maintain 4 weeks of continuous abstinence, they are much more likely to stay quit, and that the longer people stay quit, the better it's going to be for them. So if treatment can push people out that 90 days, then they're more likely to stay quit. So that's where this comes from. And this applies to all sort of smoking and other health behaviors as well. 90 days seems to be a good duration before you reduce that risk of relapse. We know that after that time, in general, even with smoking, it's about a 5% risk of relapse if people have quit or have been able to make abstinence for 12 weeks. So you're really trying to get people to have continuous abstinence for as long as possible, ideally 12 weeks. Youth, and adults with mental illness or substance use issues who are exclusive vapers, offer them combination behavioral therapy, so tapering, CBT, etc., with or without pharmacotherapy to help quit. Just depending on how stable they are, how much they're vaping, and how much executive functioning they have available to follow through with behavioral interventions. People who are pregnant, breastfeeding, chest feeding, vape exclusively, and want to quit can be offered behavioral therapies as a first-line treatment, and NRT may be considered as a second-line treatment. And you can see the icons below. With pregnant, breastfeeding, chest feeding, when developing the treatment plan, consider the impact of the stage of pregnancy on nicotine metabolism. We know as women get into the second trimester, their bodies break down nicotine much faster. So sometimes they'll end up needing more, and they may be surprised, or they may be feeling ashamed to tell you that they're feeling more withdrawal, or they're using more. And so be mindful for that. And sometimes NRT, if it's being used, may need a higher dose, especially in the later part of the second trimester. So hitting about 28, 30 weeks, suddenly they say, hey, you know what, my nicotine replacement's not holding me. I need more. I'm craving, I'm relapsing, etc. But the metabolism relapse goes back to normal about 4 weeks postpartum, so NRT dose may need to be reduced to prevent side effects. Healthcare providers should consider extending treatment during postpartum and post-breastfeeding periods because the highest rate of relapse is in that first 6 months, sometime almost immediately after giving birth, because for the most part, women quit for the pregnancy, not for themselves. And so in general, it's ideally situated that you have a woman-centered approach to quitting and pay attention to her beyond just the pregnancy. And frequent clinic follow-ups are advised because there are other issues often going on other than simply vaping. Some individuals may require longer treatment if they have mental illness or substance use. And again, integrate that with their mental health and substance use treatments where possible. One of the things to note is that if people are exclusively vaping, in general, the nicotine is not going to interfere with the metabolism of several of the medications that they are on. That interference happens from smoke, and that you don't see happening with vaping. So that's something to keep in mind as well. Dual use. People use both tobacco and electronic cigarettes. We need to think about them as well and advise them who are both dual users to switch completely from smoking to vaping only. We know that if people continue to dual use, we recognize that they are less likely to quit. If they've made that switch, then encourage them to do that complete switch. It's not meant to be, I can smoke when I can and I vape when I can. That's not a good state to be in the long term. It's really helping people move towards vaping only. If they've quit smoking and are only currently vaping, encourage them to quit vaping after they've had that 8 to 12 weeks of not smoking. And of course, that has to be done carefully because you need to discuss both the risks. For example, you pressure them to quit vaping and then they relapse to going back to tobacco cigarettes because they suddenly believe that that may be more comfortable, it's better, it's less, it's a known factor. And so you don't want them to force them to quit. You don't want them to really do it in a way that they can tolerate. And of course, you don't want them to experience nicotine withdrawal, which can be quite severe, especially if they've been using high-dose pod-based devices. And balance all of these risks with the benefits of quitting vaping in their clients. And if they're, of course, seeking treatment in Ontario, you can join the Stop on the Net program from anywhere. They'll be sent 8 weeks of free NRT, patches, and choice of gums through the mail. And those who vape will be provided an option to enroll in an online program designed to help people to quit or reduce vaping. And so you can, the link is there. And so, Natalie, I wonder if you can kind of paste it into that, the Stop on the Net link into the chat in case people want to look at it. If this is only for people in Ontario, if you do want it in your region, do email us and we can talk about how to make it available in your region as well. If that's of interest, especially if you're a policymaker or decision maker, we're quite happy to talk to you about how to make it available in your region. Medication strategies. There's no evidence for using medications to help people quit vaping. All of them are preliminary results, whatever's been out there, and adapted pretty much from smoking cessation interventions. Use of smoking cessation medications for vaping cessation should be considered off-label in most jurisdictions. And again, please inform clients that medication options are based on tobacco cessation treatment approaches and not specifically on vaping devices. I'm not sure what happened with this slide, but this is adults and youth and people with mental illness who want to quit vaping and are willing to use pharmacotherapy can offer them one of the 4 options that we have: nicotine replacement, varenicline, cytosine, and bupropion if available. There's no agreement on the recommended strategy who are pregnant, breastfeeding, or chest feeding. So take a person-centered approach. And that's what the committee suggested. The special consideration is many of us felt that using varenicline as a first-line medication made a lot of sense because, one, it's the most effective against nicotine, regardless of the amount consumed. And why is that important? Because when people are vaping, it's very hard to know how much they're actually absorbing. So they may say, I'm using 1 pod a day, but you have no idea how much nicotine they're absorbing from that. Even if they tell you, well, it's a 6% or it's a 1.8%, whatever, it doesn't matter. it's hard to know how much they're getting. And so dosing with patches and it can be kind of, people have tried to do calculations, but I think you have to be a little careful because there's such variability in the devices out there, and they change. And especially if they're refillable or, much more cottage industry sort of produced products, you have no idea that it's there. Prescribing pharmacotherapy suggested for adults, youth, and people with mental and substance use issues that demonstrate symptoms of nicotine intolerance and withdrawal. I think Lauren asked a question: is could you use is varenicline considered safe for youth? And yeah, and thank you, Laurie, for answering Swati's question. But in general, when we speak, we had an adolescent medicine physician on this panel as well. And in general, as you know, most medications for most conditions, not just smoking or substance use, have not been trialed extensively in young people. But given that varenicline is not generally is not generally metabolized by anything, it comes into the body, it leaves. It's a very specific nicotine receptor partial agonist. The idea was, to be able to use it, there's dose adjustments are not generally done by weight, they're done by kidney function. So really significant kidney functions would require a dose reduction, but really you're dosing it based on tolerance to the medication. So so that would be okay. But again, in that decision of using it for youth, you've got to decide, there's youth who's like closer to 12, who's just been found and sent, to the principal's office because they were found in the bathroom vaping, versus the youth who's closer to 18, vaping 2 to 3 pods a day, gets withdrawal symptoms, documented withdrawal symptoms when they start to stop on their own. They're very different. So I think you have to really assess before you say, is this going to be safe or not safe in a kid? The good thing is, varenicline by itself doesn't really do anything if you're not smoking. So it doesn't do anything. It may make you nauseous a little bit, but that's it. Doesn't tend to do anything else. Okay, so what about behavioral therapy strategies? Again, there's limited evidence for people to quit smoking, but again, these have been really adaptations of existing smoking cessation interventions. But discuss with the client which strategy they prefer and the best supports for their cessation journey. So you can encourage them to use one or more of the following strategies. See a healthcare provider for one-on-one counseling. Use an app, which is behavioral app, which is about setting targets, goals, reducing, managing cues, cravings, etc. And similar, those are web-based programs or text-based programs, which have been shown to be useful for youth quitting smoking, and or call a helpline for cessation support. So any of those options they can use, and really the person whatever fits is used that. For pregnant, breastfeeding, chest feeding, again, try to integrate it with their postnatal infant care, and again, of course, make sure that childcare, etc., are made available so they can attend. Try to involve the client social network where possible and family members to increase motivations to quit. But most importantly is that they are also quitting, because we know that if a woman is with a social circumstance where the partner is smoking, they're half as likely to quit. And so really making sure that they have the social support in place without the guilt and shame is really critical. And sometimes you have to do that on a case-by-case basis, because sometimes it can be counterproductive, actually. So be really careful about how you include them. With youth, integrating peer supports and peer-led counseling groups may be beneficial to treatment adherence and success, and focus on providing self-management skills, because a lot of consumptive behaviors in young people is because they haven't figured out ways to deal with negative emotions, negative affects, and often the way that society tells us to cope with those negative feelings is to consume something. But there's also ways to breathe through it, and there's also ways to expend that energy, which we don't necessarily develop at the skills in adolescents or young people. And that is a critical issue of learning those self-management skills of managing distress, uncertainty, etc., that can help reduce that need to consume something like nicotine. With people with mental illness, substance use, more frequent counseling and peer support, again, to be able to adhere to treatment plans. And again, as we've talked about, a sex and gender approach is critical. Harm reduction related to vaping devices. So now, overall, you can see as in nicotine harm reduction, obviously the cleanest form and the safest supply of nicotine would be through providing nicotine replacement. Doesn't have any of the 7,000 chemicals except nicotine, and that too being absorbed through the venous system, through the skin and the mucosa, not through the arteries and the lungs. So that's the most harm reduction. Intermediary comes vaping devices and then these heat not burn devices. But clearly, when you're looking at vaping devices, so clearly vaping devices that do not include tobaccos are better than the ones that have tobacco in terms of exposure to chemicals. But the device itself should not be modified, especially we had this sort of outbreak of EVALI, what was called lung injury, significant lung injury. This happened prior to the pandemic. But the attribution has been to actually people who are vaping extracted THC, and extracted THC is vaped as an oil, and our lungs don't like to inhale oils. And that's where the vitamin E acetate was also a contaminant, or put in there. I shouldn't say it's a contaminant, it was likely placed it there. But again, that all of those things make it oily and a suspension, but THC then, that's what seems to have caused that lung injury. And so really try not to modify the device, try not to add these substances to it, and do not modify the device in terms of temperature or the voltage or anything like that. Try not to purchase illicit black market e-liquids, pods, or devices because we don't know how they've been manufactured. And for the most part now, reputable ones do follow some sort of good marketing practices, good manufacturing practices in their production. But clearly, again, those are not to medication level. But you don't want somebody doing this in their garage, making something off and selling it off to people. Clearly, we do know about certain flavors can cause harms, like the cinnamon, cherry, menthol, and products containing diacetyl, and that flavor is like the popcorn flavor, etc. People should follow the instructions for use to their vaping device, and especially if they are using older ones, to make sure they keep it clean and replace the parts like the wicks, etc. Because they do degrade, and then they are burning and then creating products of combustion. So it's really important to make sure that they don't use devices that can blow up on them or cause them harm. Then we went into relapse prevention, offer support to people who have relapsed to vaping and still want to quit. You do have to help them get back on track. They can extend, for example, if it's been medication, extend the medication even if the person has quit. And if they're not feeling ready, so they are on the medication, they're saying, I'm not really ready, I'm really worried that I'm going to go back, you can extend it. And for dual users who have formerly smoked but who relapse to smoking, again, reinitiate, get right back on the horse. I often, get people to figure out, I said, quitting smoking or quitting vaping is a process, not an event. And I've said this for the last 22 years. So it is really important for people to understand this. It's changing that relationship with nicotine takes time. For people who relapse into smoking, healthcare providers should encourage them to quit using approved smoking cessation interventions if possible. And if people who vape exclusively unsuccessful in vaping quit attempts, try to use harm reduction to minimize their risk as much as possible. Again, always screen for relapse, because sometimes, as you know, with anything, there's a lot of guilt and shame involved in this. And so making sure you make it safe for people to reveal to you if they're having difficulties, or it's safe for them to tell you that they're relapsed, and your response isn't one of shock and horror, but one of of understanding and welcoming and thanking them for trusting you to tell you that, so that you can then move on to helping them again. So that's really important. Again, and if they do decide, look, if somebody's tried to quit vaping, every time they quit vaping, they relapse, or they have really difficult staying off vaping, it's okay for them to continue to vape and say, okay, now's not the time to come off vaping. If this is the way to stay well and not smoke, then continue vape and keep it in a way that is less harmful to you. Again, for people with mental illness and substance use, behavioral support for relapse prevention to post-quitting vaping. And again, they are more likely to relapse in general with smoking and others as well. So making sure that you're, again, using that trauma-informed, person-centered approach and getting them back on track. So long-term supports in general should be provided. And in some places, I mean, it's emerging that people with severe mental illness might need longer-term nicotine. And if you're having a person who continues to need it and seems to do better on it, then figuring out how to keep the dose low, but also to keep them reduce their harm from nicotine products. Again, as with anything else, more frequent monitoring is required for people who have these struggles. So really the main message is at this stage, there's lack of evidence in support of effective vaping cessation interventions. So what do you do when there's this demand and need and lack? Humans still need to act. And this is no different than how we had to respond to the pandemic. It was upon us. How do we respond in the absence of evidence? And so we did our best possible sort of consensus and recommendations. We did the first important thing is to look at the literature, see if anything's been published. And then from what's published and what the experts are doing, come up with some recommendations. And they are really, to be transparent, these are obviously interventions adapted from tobacco cessation. We obviously need more research to determine the effectiveness of tailored smoking cessation interventions for vaping cessation, and especially for different populations of people who use vaping devices. Very different from somebody who is 60 with COPD and diabetes and heart disease who's vaping versus a 18-year-old who's got a 1-year history of vaping and what's that intervention going to look like? Again, as we said, this guidance is a general guidance and have not been adapted by or with specific vulnerable populations. That work needs to get done. So if you do work with populations or belong to a population that's been made vulnerable or is a specific population, this may or may not apply. And so, be very humble about the use of this with populations that this, and make sure there's buy-in with and co-create that solution with the population. And as we always say, this is regardless of whether it's tobacco or not, consider that people's social cultural diversity and with anything, use a trauma-informed, person-centered approach when creating a treatment plan for people who want to quit vaping. And people say, well, why is it, is it just trauma-informed and person-centered approach? Well, here's why. We know that from at least studies that have been published about smoking, if people have experienced adverse childhood experiences as children, they're twice as likely to take up smoking. If the product has changed, it is also likely that people are using that. And it's not that trauma only happens to people when they are, little. It can happen to adults as well. And so if often we are seeing people using substances, consumptive behavior to manage hurt, trauma, etc. So we don't want to be the people worsening people's trauma. And that's why we talk about this. And so one way to do that is also to adopt a person-centered approach where the person owns the decisions being made, because there's more than one way to quit. And in the absence of evidence, we can't say use this over that. It's what do you want to try, and what's going to fit with your values and your preferences. So these are the supplementary documents. There's a list of tools: the FCFP, the EDS, which is the e-cigarette dependence scale, the Penn State Electronic Cigarette Dependence Index, and the HONK. And you can decide which ones you're going to use. The easiest one is the FDCD, but the e-cigarette dependence scale has 22, 8, and 4 items. So depending on what you want, the Penn State is 10 items, and the HONK, which has been around there, can be used with youth 12 plus. And again, they've been provided at the end. Okay, and this is some examples of what they look like. And so we have time, I think, for discussion. Yeah, we have about 10 minutes. Thinking about this, and I know there's been lots of comments on, so maybe I haven't been paying attention to the comments because I know you have, Laurie. So in our discussions of how recommendations could be made, how these recommendations could be applied in your practice. Just some thoughts and options.
Yeah, so there was a couple of questions that I saved for you that I couldn't really answer. And the first one is from Jill McKinley about prescribing NRT for those under 18. Apparently, nicotine replacement products are available over the counter, should always be prescribed because they're covered by both public and private insurance plans until age 18. And this is from the Canadian Pediatric Society website.
Yeah, I mean, I think it's off-label, like with anything else, and I think if it's coverage is the issue, access is the issue, then yeah. Interestingly enough, in Canada, there's not actually age of consent. Does the person understand and appreciate what they're consenting to, and the level of what they're consenting to? Somebody. So that's what you have to really understand if this young person is doing that. So, yeah, I think that's an important piece. One of the issues that I always worry with young people is that if you are, and this is with any addiction, that earlier on, if you're going to use, let's say, an agonist treatment or a maintenance treatment, you want to make sure that the treatment isn't going to be longer than the duration of use of the product. Right? So if somebody was, dabbling with a vaping device, as a non-daily use of a vaping device, using pharmacotherapy, in my mind, would not be something I would go to first. I would use something else. I would, try behavioral first, try other things first before jumping to a medication. Because, what's the rush? We know it takes a while to engage people and engage them in behavioral treatment. So, I think I have to pay attention, to take a look at the whole situation and then make that decision.
Great, thanks. And then another question from Ola asking about resources or handouts targeting adults who vape, that most of the resources she's been able to find are targeted at teens. I can't think of anything. Erica, I don't know if you've come across, even...
Yeah, the online vaping cessation, E-Squared is kind of adult oriented. It's not for youth, and it's not.
Yeah, but it's for dual users.
For dual users. So, yeah. But it does have that.
Yeah.
Yeah. So I think that is issue.
Yeah, and it's definitely an issue in the literature as well. 11 out of the 12 papers that were included in our review were focused on youth. There was only one looking at adults who vape.
Yeah.
I
mean, in our STOP program in Ontario, a healthcare provider can make that decision now going forward as to whether they want to use it off-label in somebody who is less than 18, but they would need to make sure that, they've done their clinical assessment. And our advice would be, make sure you've, assessed that this person is truly dependent, is in the sense that they have tolerance. If they don't use it, they get withdrawal. So you're seeing that they're tolerant to it, because if you put them on nicotine replacement, you could overdose them with nicotine and make them vomit and get headaches and get, lightheaded and those kinds of things. And that's not what you're trying to do. So, we leave it to the clinician to decide, but do a full assessment to make sure this person is actually, physically dependent on it, at least from a safety perspective. Looking at some of the other questions, Sharon says, why do we want to evaluate vaping smoking dependence? Does it change treatment? I think that's a great question, Sharon. One of the things is, which is why it was very telling to me, is we have just jumped on vaping and attributed it to tobacco and smoking and the same thing. We painted it with the same brush. And we need to do, and society needs to do some of the basic work with it to see if it actually meets those criteria. We need to do that work if you want to be scientific. because it's not right to call it that, because it may or may not have the same levels of harm. And there's a whole body of evidence that might suggest vaping nicotine is protective against smoking. And there's another body to suggest that it may get them to start smoking, but it depends on who you look at, the whole population or just a subset. So I think it's really important to understand this from a population level. It is important from a clinical level. And the clinical level, why it's important is that if you are going to try to say, I'm going to give somebody nicotine replacement, you really need to know how dependent they are, because you could make them quite sick. So that's why it does make a difference, whether you call it addiction, whether you call it dependence or use disorder. Really, the critical feature to prevent harm is to know if they experience tolerance and withdrawal to nicotine. And so that's why it changes treatment. And especially if I'm uncertain and I can't determine it, I don't generally start with like, oh, you're smoking a pot a day, here's 20, you're vaping a pot a day, here's 21 milligram patches to start. I may start with a short acting just to say, how many short acting does it take you to replace your vaping device? And then after a week or so, switch over to a patch if they're using, the equivalent of what I can get, because I have no idea when they're vaping, what they're getting. So that's a great question, and appreciate it for that. Yeah. So, yeah, and we know that even with cigarettes, milder severity much more likely to respond to behavioral than severe, which requires both. A really great question from Saba about CAT and how approach of vaping was suggested to reduce the impact of cigarettes. I mean, yeah, I mean, CAT is an interesting issue for several communities, and again, it's fallen into that. Is it a socially acceptable, not harmful within the context in which it's used, but when you bring it to Canada, it becomes out of context? And then what are the true harms from that? And it's really, is it the smoking that is causing the problem, and the use of cigarettes that go with it? Is vaping in and of itself maybe better? But I mean, I don't know the answer to that, and I think it requires study. But we do know chronic exposure to cigarettes is harmful. So as a first off, would you go to cigarette smoking, or would you, to vaping, or would you try to help them quit smoking first? And maybe with quitting smoking, that trigger to use CAT may be reduced. In other stimulant users, in some cocaine or crack users, cigarettes are a trigger to smoke crack. The ash has been used. So if they're that kind of consumer of crack, then quitting smoking sometimes helps reduce that trigger to use crack. But I don't know enough about CAT to comment. Yeah, with heated tobacco products, from a cessation perspective, we sort of looked at them that way. Any other questions or comments? Let's see. People have put in. You've commented on Quash. That's great.
There was one question farther before, a recommendation for how long before a dual user quit smoking, has switched completely to vaping, and how long do you wait before you start working with them to quit vaping?
So I mean, this is my idiosyncratic approach. I'll say, okay, are you in a, have you been in every situation in which you would have normally smoked and you haven't? Great. What's the longest time you can go without vaping? Because one of the things with vaping, I want to make sure people don't do is become a grazer of vaping, right? Sitting all day long, puffing away slowly the whole day, because vaping becomes a subconscious act. So I'm really making people understand that you don't want, I'm trying to educate them to say, you don't want vaping to become just another habitual behavior that you then will have difficulty stopping. So I wait so if they can go, they've met that milestone, they've gone 90 days without a cigarette, then I feel that that's a good time to come out, because that's typically how long I wait. I want to see that they've met these milestones before they come off, and I use it in the same way as I would, with nicotine replacement. Okay, so Marilyn's talked about vaping with zero nicotine, how to taper from high nicotine e-juice down to zero as a harm reduction method for persons who are very attached to vaping. So part of it is, again, monitoring, and maybe in the first one is use the same concentration and use less, make the cartridge last longer. Sometimes when you go down from, say, 6% to 3%, they'll say, I've come down, but now I'm using twice as many cartridges. So that's not the idea. So, you really want them to start consolidating their use, to isolating their use from other behaviors and only vaping outdoors, like when they would outdoors without anybody else. And then again, tapering from anything needs to be done at the pace that the person is willing to tolerate. And the good thing with vaping is that they can keep track of how long each cartridge lasts. So that's another way. And then going down to zero is when they're ready to do that. From, sometimes they go from, the problem is accessing it. So it's hard to find sometimes, but 6 to 3 to 1.8, 1.6, and then down. Sorry, Laurie, I thought you answered. Is there anything else that? Yeah, there's a varenicline for youth. The dose would be the same. Again, and we talked about that. But again, it's what people can tolerate. Yeah, is there an algorithm for prescribing NRT for people who are vaping? There is one floating around, and Laurie, you looked at it as well. But here's our concern with it, right? Was that it's just tells you how much nicotine, and they're taking as if everything is absorbed from the vaping device, and that's not true. Anyway, we are already at time, and so there's some information about courses and that's right. Saba, you have a great question, and we can get back to another time. But thanks everybody. To be continued, and really thank you, Laurie. Thank you, Natalie, and thank you to the committee that helped put all of this together. So we really
Thank you so much, Peter and Laurie. If anyone needs to log off, please do so. I'll just go through some quick reminders before we head off. Just a reminder that I will be emailing the evaluation and post-learning assessment to everyone by tomorrow afternoon. And along with that, I will be sharing the recording and presentation slides. And just a note that our next Teach Educational Rounds is still kind of in the works. So please stay tuned to our website or Teach mailing list or Teach listserv, whichever you prefer, for more information and registration when that becomes available. And if you happen to miss a portion of today's webinar or want to view it again, or are interested in seeing a previous Teach webinar, an archive list can be found on our website. For now, thank you all so much for joining us today, and I hope you all have a great rest of your day. Bye, everyone.
Bye, thank you.